Good evening, everybody. Thank you very much for coming. The institutes at Edge Hill, there are three. There's the Postgraduate Medical Institute, there's the institute that I'm responsible for, which is Public Policy and Professional Practice, and we have the Institute of Culture and Enterprise. And during the course of the year, we run a series of seminars, lectures, open and public events. And occasionally, we model one of the themes that I'm sure Helen's going to address, which is that we kind of do things together. We don't always do them separately, we do them together. I'm really pleased that PGMI and I4P have joined forces for this evening's lecture. Some of you will be familiar with Helen's work. I've had the opportunity of hearing her speak and reading her material. I think we're in for a really interesting and I expect challenging evening in terms of asking us to think about what we do and how we do it. Helen's going to speak for about 40 minutes, 35 minutes, and then how long you want to speak for? And then there'll be an opportunity for question and answers. Okay? Did you want to say anything, Axel?
Yeah, I do. Right, so you've been very, very modest about I4P. I think it's become over the last 3 years really a real hub of for knowledge exchange in this university, and it's a very, very active institute, I have to say. You under your directorship, I think it had something like almost 60 events in the last couple of years, and quite a few visiting professors and quite a few visiting fellows as well. So it's been very, very active. And I'm absolutely delighted that we got Helen here tonight as well. Helen is actually comes from far away, Australia, and she's now Professor of Public Services Research at the University of New South Wales in Canberra, which is really confusing because I think it's actually based in Melbourne.
Yeah, I've just now to cover as many states as I can.
And really break up the air miles. And she's also director for the Centre for Public Service Research there. And she has an incredibly impressive publication profile, which is almost intimidating, I think. 16 books and about 50, peer-reviewed journals, and not to speak of all the other publications that are, appearing in grey literature, in non-media, and all her many media appearances. And she's also co-editor of the Journal of Health and Organization Management, where I get from time to time requests to review. She's also the co-editor of the Australian Journal for Public Administration, and she worked previously at the University of Birmingham. I came across Helen's work about 8-9 years ago when I started working in partnership, and what I realized very, very quickly is there's no way you cannot bump into Helen's work one way or another when you work on partnerships. She has really developed an international reputation as a leading expert on partnership work. And what I particularly valued is when I read her first work on partnership that she edited with John Glasby on partnership work. What I really valued is she has a very critical attitude to some of the things that are going on and sometimes we believe are happening in partnership work, but may not turn out to be, really, when we look more closely. And that's one of the things I noticed, one of the main messages that came out of her earlier publications is there's a significant evidence gap in what partnership actually achieves for people, service users, patients, and others. And usually, if you have an evidence gap, you could either give up or you could drill down further into the problem, and that's certainly something that Helen has done. But she has retained a real critical attitude, I think, to partnership work, as well as a positive critical attitude, as well as to what we now call integration. And I remember her publication, Public Management Review with John Glasby. And I think it ran something, the headline or the title was something like, Why Partnership Doesn't Always Work, or something like that. So what I really valued right from the beginning in her work is And she really not just asks why something does work at some point, but why also it doesn't work in many instances, and whether or not we can find good explanations why and can improve. And that's one of the things that I'm really looking forward tonight, a very critical and appraisal of a particular problem in Australia, the welfare reform. And so I'm absolutely delighted to welcome Helen to this public lecture. Thanks very much.
Thank you. Well, thank you, John. Thank you, Axel. Thank you all for being here. I might end up giving pretty much exactly the same presentation I gave on Monday, so don't get too excited, Axel, in terms. Right, so today I'm going to talk about the boundaries that we find in disability services and the challenges that they pose for people who use those services. And as I do that, I guess, as Axel said, I'm going to sort of talk about one of the major challenges that has been identified in the space around disability services as being the existence of multiple different boundary types and that have traditionally operated across public services. And so, as we know, there have been concerted efforts over multiple kind of reform processes to try and address these boundaries that, as Axel says, the evidence suggests hasn't always been successful. And then in more recent years, one of the kind of ways to counter that is one of the solutions that has emerged has been this idea that actually what we'll do is we'll give power to the hands of people with disabilities through devolved budgets, and we'll use that as a way of better joining up services and getting rid of some of those boundaries in traditional services. And so I'm going to look at some of the evidence of these sorts of schemes from England and then from more recently from Australia, from a new large scheme that's been rolled out. And just as a bit of a spoiler alert, if you don't want to hear the ending, kind of put your hands over your ears now. But essentially going to argue that boundaries are a kind of a pervasive sort of thing. And actually a lot of the effort and a lot of the time we've spent has been trying to change these structures in various ways to overcome these boundaries. But actually there's a certain inevitability to these sorts of things. And actually we need to think about different ways of dealing with these issues rather than just a purely kind of structural perspective. So I was going to tell you something about me before we got to that point, although you've heard quite a bit about that from Axel already, so it doesn't need too much saying. I guess I've been researching this sort of area for about 12 or 13 years now, 8 or 9 at the University of Birmingham, and then I moved to the University of Melbourne about 4 years ago, and then, as Axel said, to the University of New South Wales in Canberra, confusingly, about a year ago to set up a new research group, and have continued this kind of line of research. And there's some of the kind of more recent publications. At the moment I run something called the Public Service Research Group, which is, it sits in the School of Business at UNSW and brings together about 30 different academics who work across a heap of different kind of disciplines. So we've got accountants, economists, kind of public admin, public management, public health people, and we work in what we call a kind of interdisciplinary, intermethodological way, and that's because that's the way the real world is, and problems don't line up in those easy sorts of ways. So we're most interested in implementation, which in Australia is a weird thing for a group like ours to be interested in the policy space. The economists kind of have a lot of the ground around public policy, and so you tend to find groups are more interested in the design of policy rather than what happens when it gets out into the real world and gets messy. And that's the bit that we're kind of interested in. So the people we brought together in this group are all do quite applied work. They publish in kind of in the really good academic journals as well, but they're interested in translating what's useful in terms of that knowledge and evidence into kind of policy and practice, and kind of informing that context. So we're a fairly broad group, as you'd imagine, with those sorts of disciplines. So we organise ourselves around these 3 major themes. One around large-scale reform and system change. So some of the NDIS stuff I'll talk about today fits in there. The other big bit, as a complete aside, but the other big bit of work that sits in there at the moment is Australia's just discovered commissioning. and is exploring it with gusto because it's worked so well in England, apparently. So we've got quite a lot of work around commissioning and health in that space. Another theme that I lead around diversity, inclusion and equity, and a final one around public service capability, so culture, performance management, and those kinds of issues. So that's my obligatory plug that I need to kind of do. So onto boundaries. I mean, as Axel said, we have many different sorts of boundaries exist in public services, and we recognise that they're divided in many ways by these. So we have boundaries in terms of the organisations who deliver these, the professions who are involved. We have geographical boundaries. We've got boundaries around time and knowledge and resource and all those different sorts of areas. And they're kind of fundamental to our traditional ways of organising public services. And so many people have written about the fact that contemporary public servants, one of the major kind of roles that they have is in navigating this complicated terrain around kind of boundaries, and that boundary work almost has become a kind of modus operandi of the 21st century public servant. We also know that working across boundaries is really quite difficult. It takes quite a lot of skill and attention and time if you're going to be able to do that sort of work well. But nonetheless, we've seen these big kind of policy pushes to try and encourage the amount of collaboration that we do across boundaries. And that's because the case is often made is that boundaries are very bad for efficiency and effectiveness, and also for the outcomes that service users kind of receive as a result of this. I mean, in some ways, given the evidence gap that Axel talked about, it's a slightly strange argument because there's kind of very little evidence around the kind of really effective collaboration improvements in outcomes, but there's a kind of a face validity to this idea that if we look into, for example, serious case reviews around child deaths or a number of the kind of challenges that people face in accessing public services, that often a failure to join up across agencies is cited as being a problem. And so there we say, well, the challenge then is that we don't do boundary working very well, so therefore we need to do more of it and we need to do it much better. We also know that the greater number of services that you access, or the more disadvantaged you are, the more likely you are to feel the impact of these boundaries. So the more that you come into contact with services, the greater number of services that you come into contact with, the more likely it is that you're going to feel at least some of these sorts of boundaries in your service experience. And the argument goes as well in terms of the quality of your outcomes. So since at least the early 1990s, we've seen these repeated kind of attempts to kind of better join up services and work more effectively across boundaries. As in England, kind of called partnerships at first, and then partnerships slightly lost their lustre and we went into kind of collaboration, and I guess integration is the most recent incarnation of that. But certainly when I first started to study in this area, when I first started to do my PhD, that when I went out and to talk to colleagues who worked in practice, there was no way that you could do any project or do anything unless you put partnership somewhere in your request for money. Everybody had to do partnerships in some sort of way. But as I say, and as Axel talked about, we don't have a huge amount of evidence that this improves outcomes. Now, in a very typically academic statement, that doesn't mean that they don't. And actually, there's lots of reasons why partnerships are incredibly difficult. Collaboration is very difficult to evaluate and to attribute changes in organisational practices to what are often really kind of high-level outcomes that are interested in inequalities, very long-ranging sorts of issues that take quite a while to address. But there's this sense that there's this evidence gap and that really something hasn't worked here, and that we've tried a series of different things over a number of years, and although we've got evidence around some kind of single case studies and areas of good practice, we haven't found a single kind of approach that delivers the good across the piece. So in more recent years, what we've sort of, I think in the disability context, what the attention has kind of shifted from joining things up across organisations to thinking about how we devolve power and control to people with disabilities to try and do some of that joining up in a more kind of bottom-up way. So the argument here is, well, we've tried to do this for a number of years, we still haven't managed to do it. A number of these boundaries still pervade and they cause challenges for people when they access these services. So what we need to do is give people budgets, we need to give them choice and control, and we need to allow them to kind of act to join up these services in much more effective ways than we've managed to do through organisations. So the argument here is made that what we've often done is thought about the services from the perspective of the system and not from the people accessing them. That's why we get these different sorts of boundaries. And so if we were to think about this from a service user perspective, we'd think about these services in different sorts of ways that wouldn't be kind of hamstrung by these traditional delineations between different sorts of services. And so we've seen these successive kind of reform processes. We've seen people like my former colleague John Glasby at the University of Birmingham describing the social care system as being fundamentally broken and in need of a kind of a new idea. And this idea is that you devolve budgets down to the service user level, away from organisations, and give individuals more choice and control over them. And as a result of that, individuals will develop more joined up services. They're not going to need to work to the same sorts of traditional lines that we have done, and so people will be better able to achieve their identified types of outcomes. So what I'm going to do now is have a think about the evidence from England and Australia and think about whether that sort of line of argument has demonstrated to be true today. Now I assume most of you are more familiar with the English policy context around this, and so I don't need to give as much background around some of that as I will do in terms of the Australian example that I'll talk about. But as you'll all be very well aware, one of the fundamentals of the English system is it's based on this assumption that you can decide what's a health need and what's a social care need. So when somebody presents with an issue, we know that if you've got a health need, you can receive that from the National Health Service and you get that free at point of delivery. Provided you've got a British passport, I hear now. And if you've got a social care need, you'll receive that from local government and maybe subject to a means test and potentially a charge around that as well. So delivered by different organisations and different funding mechanisms around that. Of course, life is never quite as straightforward as those two things, and particularly if you've got complex or chronic issues, dividing issues into health and or social care needs is an incredibly difficult one to do. And so and we've seen a variety of different funding mechanisms introduced progressively from the late 1990s and mainstreamed in more recent years to try and think about how we better join up services through user power and control. And so if we look into some of that research, what we do find is that some work that John Glasby did about 10 years ago when he looked at direct payments, the kind of cash in lieu of service payment, he found that people were spending that social care money on both health and social, or what would be classified as both health and social care needs, despite the fact that theoretically and kind of legally you weren't supposed to be spending this social care money on health-related needs, but this is what people identified as being important to them. So there's an argument there that to some extent some of those boundaries were being broken down. And then we saw the kind of use of the piloting of personal health budgets and for those eligible for continuing healthcare and the extension of that after that. The personal health budgets were interesting in that they were quite positively evaluated, I guess, in some sorts of ways, which is, and particularly in terms of those who had the greatest level of need reported the greatest kind of improvements, which is a kind of an interesting finding given that the review into individual budgets that was done a couple of years before that found a number of challenges in terms of integrating different streams of funding. So the Ipsen review that Caroline Glendinning led found that although individual budgets were designed to combine a number of different funding streams into kind of one pot of money, this was largely unsuccessful and a really difficult kind of challenge to achieve. And some of the sorts of barriers that they talked about were around legislation, accountability, market management, and concerns about demand increase. You know, all quite traditionally administrative issues that you'd think that you would encounter in a traditional administrative system, not necessarily in one where you devolve budgets to people with disabilities. And there was this kind of concern about financial buck passing, so that you would be spending social care money on something else that wasn't social care related, and that you might have one resource stream being used to prop up other resource streams. So many of you will remember, you know, before the kind of major reforms that happened in the late sort of 1990s onwards, these kind of financial buck passing and this competition between agencies is something that's reported as being quite rife, as something that maybe wasn't addressed through some of the reforms of the 1990s, 2000s, but certainly the amount of money available in the systems maybe helped kind of overcome some of those sorts of issues. And we saw a re-emergence almost of these kind of debates over boundaries and terrains emerged as a result of the individual budget pilots. So what we know from the English experience is people don't necessarily spend budgets on what we'd classify as being the traditional kind of services, but that doesn't mean those boundaries and those challenges go away. They're long-lasting and pervasive, and even though you've got users being in control of these budgets, they still feel the impact of kind of administration and the kind of legislation and the traditional kind of demarcations. So having said a bit about the English experience, I'll talk to you about the Australian experience now. So in recent years, Australia has seen the introduction of the National Disability Insurance Scheme, the NDIS. As its name might suggest, it's national, it's for people with disabilities, and it's based on an insurance model, which is quite sort of unique, really, in the sense that it's a very actuarial model of insurance. So it's quite different from a Western European social investment type approach. It's very different from the kind of social insurance models that you see around the world. It's literally it was created by economists who argued that disability essentially is an incredibly inefficient thing for the economy, and that if we provide better services and provide earlier intervention, then it's more likely people with disabilities will be included in the mainstream, will go into employment, education, training, will pay tax, and will not have the kind of, the kind of inefficiencies and negativities that associated with the kind of poor state of services before this. I won't go into this now, but I have some problems with the argument. But one of the issues there was what they were arguing for, though, the sorts of changes to some extent were those that people in the disability activism community have been asking for some time. So Australia has traditionally organised its disability services by state and territories, so they're very different availability across those spaces. They were quite badly funded, huge waiting lists, and outcomes for people with disabilities are kind of poor as well. So if you compare quality of life outcomes for people with disabilities across OECD countries, Australia comes bottom. The Australians are very competitive, don't like to come bottom in anything, so I said, right, let's. They get annoyed when I point out, how many gold medals Yorkshire got in comparison to the whole of the country at the Olympics. That doesn't win me many friends, but anyway. So this system has been introduced as a kind of described as a peace of mind, so anybody who might have or acquire a disability. So there's an important equity issue here as well, because pre-existing this scheme, there were a couple of schemes around insurance cover at work, and also in some states like Victoria, and I think in Western Australia, they have, when you pay your car registration fee, your road tax fee, there's a component of that goes into a no-fault insurance scheme. And if you have a road traffic accident and become disabled as a result of that, you get your whole of life costs of care covered through that scheme. So you had this bizarre scenario where if you were born with a disability, you might not be eligible for any kind of funding or cover around your disability-related costs of care. But if you got injured at work or you're in a road traffic accident, you'd be eligible to have quite generous amounts covered through that. So that was seen as being fairly inequitable and something that should be addressed. So it started in 2013, and what happened is they introduced a trial site in each state and territory and kind of looked at how that would work. And then as of July last year, started to roll it out nationally. It's going to be a a process to roll that out. It'll roll out at different speeds across the country and should be across the country by 2019. The figures suggest that about 460,000 people will access the scheme, although there's some issues with the figures that we may get into at some point later on. And it's thought it might cost around $22 billion. There isn't a cap on the budget, and it doesn't come out of a hypothecated tax, so it doesn't have an amount set aside for it. Again, another challenge for the scheme, and it's talked about as an uncapped scheme, which terrifies many people in Treasury, as you would imagine. And as I say, really the case for it was this idea that we had very inflexible, underfunded and equitable disability services across the country. So this is broadly a kind of an organogram of what the NDIS looks like. We've got Commonwealth or federal government in there and the state and territory governments, and so this is a new space for the Commonwealth government to move into, because they've traditionally not played in this space and left it up to state and territories to run this. There's an organisation called the National Disability Insurance Agency, which is they kind of oversee the administration of the National Disability Insurance Scheme. We have people with disabilities in the community and in theory with choice and control over disability services, and because it was recognised that actually some of that process is quite difficult, navigating services can be a quite challenging process. There was this new role of local area coordinators introduced to kind of tidy some of that interaction up, and I'll say a little bit more about that and how that's working out in a second. So there's a bunch of different, so we've got about, the Public Service Research Group, we've currently got 5 different projects which investigate different parts of the National Disability Insurance Scheme, and I'm going to draw on a few of those projects today when I talk about some of the issues relating to boundaries. Most of what I'll talk about comes out of interviews we did with policymakers in federal and state governments, but also with individuals who access services through the NDIS, and in some cases the families of individuals who access the NDIS as well. And I'm going to talk about some of the boundaries that have emerged today in terms of who's in and out of the NDIS, what's in and out of that, and something about this role of local area coordinators as well. So on this question of who's in and out of the NDIS, so the NDIS was designed to provide individual funding to the people with the most significant levels of disability within the community. And so these are people who have really high levels of impairment, lifelong disabilities, which, given that mental health was added on quite late in the game to the NDIS, and given kind of episodic nature often of mental health issues, has caused a huge amount of challenges, as you might imagine. But so only about 20% of people with disabilities will actually access the NDIS through the individual funding scheme. The remainder of people with disabilities will still receive services out of mainstream health and education services and so on. Unlike the English system, if you're over 65, you're not eligible for the NDIS. The slight complication is if you go into the NDIS before you're 65, you can stay in it, but you can't access it after that time. And so really what we find when we talk to people about the NDIS, about some of the issues around boundaries and who's in and out, is that people kind of in the mainstream services say, well, you know, the NDIS has got all this money, you've got $22 billion. They're all about people with disabilities and supporting all people with disabilities. So the people over there have got this disability stuff covered. We don't have to worry about that. You know, we don't have to worry about making our services accessible or kind of translating into that into those communities, because that's covered. The NDIS has got that sorted. So there isn't this kind of acknowledgement that that this is actually only about 20% of the population of people with disabilities within the country. So one policymaker who he's talked to said, the NDIS rollout is brilliant, but of the 4 million people with a disability in Australia, not a huge proportion will actually get a funded plan from the NDIS. And for many people with disability, it's the mainstream services that they interact with every day the health system, education, transport, criminal justice, all of that. And the risk is that there aren't constant reminders and pressures maintained on those systems. And they'll tend to just think that the NDIS takes care of everything in disability land. And there's this unintended consequence that we want to try and guard against. The NDIS is the biggest game in town. It gets all the media attention, but it doesn't cover all people with disabilities. So they say one of the justifications for the scheme was that there were these inequities between people who were born with disabilities and those who acquired them, and that this was one of the boundaries that the scheme was supposed to address. But we see another boundary emerge between the people who are deemed kind of eligible for the scheme and those who are not. As I say, broadly, it's thought that about 20% of people with disabilities will be eligible for the scheme, although in some of the trial sites, particularly in South Australia and the Hunter Valley trial site in New South Wales, one of the things that they found is the initial studies that the Productivity Commission had done that had estimated the number of people with disabilities has severely underestimated them. So what a surprise if you don't have very good disability services that are underfunded, fragmented and things like that, you don't have a good handle on the amount of need within your communities. And particularly children with autistic spectrum disorders have been a kind of huge group who've been been more represented than thought that there would be. So there's this challenge about who gets in and who's out of the NDIS. But there's a similar challenge in terms of what's in and what's out of the NDIS. So there's this argument that it's about choice and control. It's giving individuals the ability to design and to choose their service and direct them in the way that they want to. But when you become eligible and you gain access to this, you go into a process of care planning where you work with a care planner, in my experience, who often has no experience of disability, because that's seen as a good thing, because you don't have a vested interest, but who is trained in a planning process. And they must judge whether what you've requested is reasonable and necessary. Okay? So is something that you've asked for something that is a reasonable and necessary requirement? There's not a huge amount of information about how that's defined. It kind of gets used in practice. So some ways that gets defined is you'll be sent off to have an assessment by an occupational therapist or another professional. Occasionally it gets into slightly kind of inefficient territory where, for example, I was talking to a woman with a degenerative neurological condition recently who wanted a kettle tipper to be able to pour hot water and stop burning herself, and she'd said this to her care planner. I think they have some in Aldi in Australia, which we have also, and they're about $30 to buy. And so she said I could just go down to the shop and buy this. She said, well, we have to check if it's reasonable and necessary for you to have that. So sent her off to the occupational therapist for an assessment, which cost just over $100. And they decided that it was reasonable and necessary to have a kettle tipper. And so therefore, she was allowed to buy it then. So it became quite an inefficient bit of kind of purchasing. Other things that have been deemed reasonable and necessary are things like an individual with a visual impairment who uses a guide dog. Food for the guide dog wasn't seen as reasonable and necessary to fund out of the care budget. So in one sense, you know, fair enough, and the argument was made that many of us feed our pets out of our own budgets, but in another sense, a guide dog isn't a pet, and also what we know from the data about Australia about the kind of levels of social disadvantage that are experienced by people with disabilities, actually that's quite an expensive commitment if you're on a very limited budget. The other thing in terms of, like the English system of what's in and out in the NDIS, is this area of debate over what sits in the NDIS and what sits in mainstream services. And so here on the screen we've got a quote from a guy that we spoke to recently who has MS. He's in his mid-50s, he's had it for a number of years, he's in an electric wheelchair, and he was trying to get some services funded out of his plan that the planner said, well, that's actually a rehab service, so we don't do that, that's health. Health do rehab. We don't do that, we do care services. And he was saying, well, actually, this isn't about, you know, I don't think I'm going to go to this service and I'm, you know, going to hop up out my wheelchair and I'm going to be able to do all of this stuff. It's about me keeping the mobility I have in my right hand, which is the only hand I can do anything with at the moment. I don't think I'm going to get better. I want to keep it at this level. And he was told that, well, no, that's health is rehab, so we can't fund that out of the NDIS. And then, as I said, health is kind of pretty sure that the NDIS has got disability services covered. So people find themselves in these kind of gaps between services again. Another parent of a child with intellectual disabilities told us about how the NDIS is being kept very separate from the Department of Education, and they described being really worried about it because they'd heard a lot of things about how therapists can't go into the classroom and things like that. And I'm really worried about how it's going to impact his learning, basically, and that it's going to work. It's impacted us already. Before he was accepted into kinder, there was no daycare centre that basically wanted it. They turned us away. So people with disabilities in schools finding it more challenging to kind of access the sorts of services that they need. People with communication difficulty being told you can't purchase an iPad through the NDIS, that has to come out of the Department of Education, and those old kind of boundary debates that come up. Seen some really creative examples around this as well, and people being really quite innovative around some of this boundary work. So this was a parent of a child who I met recently who was describing her experience working with a planner. And so you go through an annual plan generally, and you set for the next year. In some cases, people can go for 2-year plans, but typically it's a year. And this mother was saying, well, there's not a lot of stuff in this plan that's about fine motor stuff, and I wanted to make sure that we had something allocated for that. And so she said to the planner about needing an extra goal in there around fine motor skills. And I want to improve my son's fine motor skills so he can learn to write. And she said, I'm really sorry, but that's an education goal and we don't fund those. And so she sighed and said, I'd like to work on my son's fine motor skills so he can learn to do up his buttons. She said that's a great and excellent goal, and they got that service funded through the NDIS. So a really kind of creative example of somebody doing some work to make sure that she got the sorts of services that she'd identified as being needed within there. And there's another couple of examples of where people have kind of managed to do that, and I think it's telling that she's into at least the second plan here, so she's starting to work out this system and how to work it. But I guess one of the concerns that I have around this is not everybody has the ability, support, capacity, understanding of those issues to be able to do that. And one of the other things we've seen, again, quite similar to some of the experience here, is that the space for advocacy has reduced. Advocacy has not been funded in community organisations in the same way as it was, because it's assumed to be a part of this entire sorts of systems. And so, although in this case it was okay, one of the concerns I have about these sorts of schemes is in more uncharitable moments I'd describe them as an incredibly middle-class policy. So they do very well for those sorts of groups, but not necessarily for the most disadvantaged, where we're supposed to be kind of addressing these issues. So I talked before about these local area coordinators who are supposed to sort all this stuff out in the middle. And we've got a project that's ongoing around this at the moment. And one of the things that we find is it's really not very clear what these people are supposed to do, what some of the role is. In some places it's being kind of wrapped up with the care planning role a bit, which is also slightly problematic. And when people tend to kind of describe this role, they describe it as one of our interviewees did as being, this is the Superman type stuff. They're going to do all of this stuff and do it really well. So the idea is that these help people navigate the local service terrain. A very new disability market is emerging, and really quickly, and it's very difficult in many places. In the more metro areas, I think in the rural and remote areas there's still not a huge amount of providers or competition, but in the metro areas it's very difficult to keep up with the new providers that are entering this space and how that's shifting. And so that's one of the job of these local area coordinators. But the other thing that they're supposed to do is work with the other 80% of people with disabilities who don't get access to the scheme and to the general kind of population to do work around early intervention, prevention, making mainstream services more accessible, and making what's called the mainstream community, which is people who are not identified as having a disability, more accessible to people with disabilities. So they've got this huge kind of role to operate there. And to me is really important as well, given, as I said, it's based on this actuarial modelling. And so how you drive these efficiency dividends if you're not doing early intervention and prevention and inclusion is a real kind of challenge. So there's a whole series of boundary issues around the role of local area coordinators as well. So one of the things that when I look at the evidence from the two kind of countries that sort of suggests is that even though we've got this great idea that we devolve control and choice and power and things down to people with disabilities, and that they in turn will be able to reduce some of the traditional boundaries, that doesn't seem to be happening across the board in these two countries. And some of that's because some aspects of the system aren't working. And I think it's also important, I mean, some of what I've said, quite a lot of what I've said already about the National Disability Insurance Scheme has been more negative. But on the flip side, the kind of real positives are there is far more money in disability services than there was before. It frustrates me that a lot of it is going into transaction costs around OT assessments and various other sorts of things. But we've got far more money into disability services, and a number of people who we've talked to report being able to have more choice about, you know, really important issues like who comes into their home and works with their children, which is, you know, an absolutely kind of crucial thing. But we've had such a big investment. I think it's really important that we see the kind of results of that come out, and there's a number of really easy fixes that would alleviate some of that. But even if the system was working entirely kind of correctly, and I think the same is true in the English system, what we see is these boundaries still exist, and some of that's because there's an inevitability around boundaries. So when we look in the public management literature, there is this sense that you can move and remove, and we'll just get rid of boundaries. If any of you remember back to when Alan Milburn was the Secretary of Health, he talked about the Berlin Wall between health and social care, which is a very particular metaphor about a very kind of solid structure that, you know, is there and is this huge kind of material divide that would be very difficult to get over, and you know, you might get shot on your way over it at a particular point in time, but there's a big kind of cultural divide across that as well. And there's often this sense that what we need to do is break down boundaries. I think that's not a terribly helpful metaphor, and actually what we need to think about is actually where we put boundaries and acknowledge that we're always going to have them, and actually having acknowledgement of where they are and some of the potential impacts that they may produce is a more helpful way to approach this than getting rid of these altogether. So if we look into the sociological literature about human cognition, they tell us that boundaries are absolutely necessary for how we make sense of things as humans, and that you need to kind of cut things up and lump things up in particular ways to do that. But if you're not cognizant of the challenges that organising things in your mind or in reality in those ways cause, it can be problematic. So I think what we need to do is think about these kind of notions of healthy kind of boundaries and how we use these, and also probably acknowledge that boundaries can also have incredibly positive impacts as well as just negative ones as well. And I'm happy to say more about that in questions if that's something that people want to pick up on. I just thought I'd finish by so you don't do that terribly academic thing of point out all the problems with something and then providing no solutions to anything at all. So to kind of think about what I think are some of the helpful things in thinking about how we do boundary work. And in doing this, I'll draw on a paper that is in the journal that Axel is an editor of, Journal of Integrated Care, that was out a couple of years ago. And in this occasion, essentially what I sort of argued is if you look at a lot of literature on integration, there's this very scientific kind of vein to some of it, and we see some of this with the enthusiasm for RCTs and randomised controlled trials and various other things that's emerged in recent years. And there's this sense that, well, there's one good way to do integration, and if you just control everything, and if we just have a really good method, and if we just research the shit out of it, we'll find what the kind of factors are, and then we'll be able to reproduce them everywhere. And I think there's a problem with that sort of approach, given that collaboration, you know, fundamentally is based on people and people doing things together and relational kind of capacity. So it's therefore relies on the skills of people to work collaboratively. And so I talked in this article about collaborative working being less of a kind of a science and more of a craft. It's something you need to practice a number of times. It's you need to have experience of. You probably just can't sit and learn about it in theory and then do it. You need to have some experience of this sort of approach. I also talked about it as being, and this doesn't go down well in Australia at all, given such a northern idiom, but as being around graft. It's about hard work. And this is something we often kind of forget about. We go, let's look at all those factors, structure a team in that way, we'll put them together over there, and ta-da, the magic trick will be done, we'll have great integration. Actually, and I'm sure many of you have seen this in practice, it's quite a lot of hard work. There's a story behind it. It goes back years often, and that often gets missed out in snapshot kind of research that just looks at a particular point in time. So in this piece, I argue for the importance of kind of craft and graft, but also really this idea that if collaboration really is this kind of modus operandi of the 21st century public servant, why do we not invest in that more? So it's certainly the experience in Australia, and I imagine it's still to a degree true in the English context, is we employ people, you're a good professional to a certain level, you get promoted to a certain level, then you become some sort of manager or have some responsibility for collaborative working, but we're not going to retrain you in that or develop you in it or value it in your professional appraisals. And so I think there's a real need to kind of invest in those sorts of skills and really, I guess, recognise the kind of the tacit skills and knowledge that professionals bring to these environments, and to I guess to value these much more in a context where I think the push towards kind of evidence-based policy and practice has kind of pushed out the space for some of these skills and abilities. So I think I'm going to stop there. I'm more than happy to take questions around anything I talked about or anything more broadly around that, around the NDIS experience as well. So, Axel. Yeah.
Thanks, Al. What really stuck in my mind is, what really struck me is that we might be asking the wrong questions when we look at boundaries. And there's almost an epistemological or ontological problem there, in the sense that we think if we only write down the right rules and follow the rules, then everybody will be able to replicate good practice somehow. And we just haven't found the right rules yet. And we just need to find this, as you said, research out. But in fact, it might be different. It might be a practice. It might be, as you said, you called it graft. But it might be almost tacit knowledge. It might be almost a sort of like a Polanyi kind of like a different type of knowledge that we really need to instill in people. And that really struck me, so that we are approaching this entire aspect from a wrong angle. Okay, questions?
Can I start? Thank you very much. I really enjoyed that. I wondered if you would say something a bit more about the healthy boundaries, because that feels like perhaps the counterintuitive observation, but I think it's been really interesting, isn't it?
Yeah.
It kind of challenges the idea that the boundaries are bad, but actually sometimes they're really important.
Absolutely, and I think there's a lot of evidence from if you think about the interprofessional education literature and you think about this desire for kind of transdisciplinary practice that people have talked about. Now, there's very good reasons why we have professionals who have particular skills and knowledges around particular areas. They have cultures and ways of working that are quite kind of positive things as well as just negative. It just strikes me in the public management literature are often crafted, as you say, in this incredibly kind of negative sort of way. Boundaries are very material things. They get in the way of stuff, and not that actually they can sometimes have these hugely productive kind of impacts on, particularly the kind of cultures and values and ways of working, and that we need to recognise the kind of positives of these as well. I mean, if you think of examples of, and this, I mean, it isn't talked about in these sorts of ways, but if you think back to examples like, I mean, where people talk about examples of good practice in integration, Torbay is often kind of, was often for a while kind of bandied around about that, and it was talked about, well, what happened there was you got the removal of this boundary between health and social care because you brought social care into a health organisation. But actually it didn't talk about the kind of really positive thing that actually, having been in a fairly parlous state, these the kind of services for older people in Torbay, they actually got a bunch of people who banded together and actually said, right, we're going to fix this, we're going to sort this out, we're going to think about how we work across this organisation and our ethos and way of doing that. And actually, some of that was due to the positive effect of boundaries. So I'm doing some work at the moment. Actually, where some of this work is really interesting is in, and actually where I started initially in my academic career is in geography, because having in geography for many years, boundaries and kind of borders between states were thought of in this similarly kind of very material, very largely fixed kind of way, but with Schengen and the opening up of the EU and countries like the US and other places moving their borders effectively out of their countries into other countries, preventing people from getting on transport and things like that. Actually, they've started to think about borders in very different ways in the geography and the borderlands literature. So I'm writing a chapter at the moment on different conceptual perspectives on boundaries for a book that myself and Gemma Carey and Luke Craven have coming out next year, which tries to conceptualise of boundaries in different sorts of ways and think about those positive elements of them as well. Yeah.
Do you also have any data about the care planners, like in terms of the training, what they have, whether they could also have an impact on boundaries they set in?
Yeah, I'm just about to start writing a paper on care planning in the NDIS at the moment, because it's a thing that worries me a little bit. I mean, there's a very routinized process that people need to go through, and there's very kind of limited training. And this is something that Australia has done in a few different policy areas, which strikes me as a bizarre thing, because we had this thing in employment services as well, of the kind of point of entry into services where you kind of meet the person who's going to help you decide, how to navigate those and what might happen. Is they are the least trained, least knowledgeable people about disability or employment services or whatever other issues that is. And that strikes me as a really stupid move in some ways, because that's the point at which you develop that psychological contract with the services as a person who's going to kind of use those. And so we've heard some fairly crazy, or I think kind of crazy things in recent months, like it's a woman in her mid-30s with autism and a very kind of complex and really kind of challenging background, who's barred from the NDIS because she exhibited behavioural problems. And there are quite a few people with personality disorders who've been barred from the NDIS by their care planners because they're not seen to have behaved in the ways that are appropriate. Now, the idea that you bar anybody with autism for behavioural problems just strikes me as a kind of slightly crazy thing to do. But as I said before, people are not expected to have knowledge of disability, and it seemed to be a kind of a hindrance in some sorts of cases. So there isn't very good evidence of care planners being really effective. And there was, at the end of last year, there was quite a lot of negative media reporting that the numbers of people recruited to the NDIS hadn't been at the level they should have been. So they put more money into care planning and push more people through the process. And now the majority of assessments and care plans are done over the phone. And so they, on average, take, I think, about 35 minutes. And you're not shown the plan at the end of that planning meeting. You receive it in an email a couple of days later. And so I have a colleague who's a medical doctor and epidemiologist, a professor who I work with, who is interested in disability and has a son with a serious kind of cognitive disability, and she received his plan after one of these kind of conversations, and she didn't understand it, and so she researched, and it didn't say the things that she thought they'd agreed. So one of the things they talked about was how they support her son, so that maybe in the future he'll think about living independently. I mean, he's 8 or 9 now, but you know, as a long-term aspiration. And all of the goals that were written in were about keeping him living at home. And I said to her, well, have you challenged it? And you know, have you asked people to explain it? And she said, well, I tried to get there a bit and then it was too complicated. And you know, actually it gave us a bit more money than we had before. So we broadly thought we were quite happy with it, and there you go. And I just think there's a huge challenge if you're a kind of, you know, you're a professor who does research around disability and you can't understand the plan that you come out of that process with. It suggests to me there might be something wrong with it. And say it's a different context to here, I guess, where you have social workers who kind of move through, or I understand in majority of those cases move through. It's not the case at all, the kind of very low levels of skills, which I just think is problematic. Yeah.
Go ahead. Is there anything, thanks again, I really enjoyed this, sorry, I need to say that first. Is there anything about the barriers between individuals with disabilities and the spaces they inhabit and the services that they're now purchasing?
Yes, I mean, is there a particular way that you're thinking about that, or?
Well, I'm just thinking about saying things that devolve down to somebody and they are empowered, but then people didn't know enough about maybe the prevalence of autism or services for people with autism, and so kind of where's the, we talk about interprofessional boundaries quite a lot, but you just wonder about the power shift and the boundaries there.
Yeah, so what a lot of people learn is you can get somebody who can be like a care coordinator who can go into planning meetings with you, but most people don't know this on the first time around, so they go into this on the second time around. That's seen as being quite helpful, although I think with the cost concerns, some of that is being pulled out a bit. But it is a major issue. I mean, so we've got a project that's looking at mapping kind of providers in 2 areas of Australia to look at how the market's kind of shaping up and how that's moving. And we can't actually keep up with how that's developing. And so actually, if I was somebody, you know, trying to think about what providers I wanted to purchase from or what services I need, that would be a kind of challenge again. I've got a great PhD student who runs an online service directory called Clickability, which is kind of designed to support people with disabilities to navigate services in their local areas. So it presents data around the services, some of the stuff that you would typically kind of ask, but it also has reviews by people with disabilities of those services and their experiences through it to help kind of inform choices. But that presupposes that you know what you need in the first place as well. And the thing is, given the kind of given the poor state of a lot of services in not in all places, but a lot of places have been for a number of years, how we expect people to know what to ask for and what they want through that process, I really kind of don't know. So I've got some colleagues at Deakin University who've been working on a resource, like a pre-planning resource for people so that they can move through a series of prompts and think about things that are important to them in their daily lives, to do that before they go into a planning process. But again, that kind of is that you've thought about that and had the ability to engage with that before you get to that sort of process. I think one of the more kind of worrying interviews I did recently was with a guy who he had a daughter who's 4, and she had a disability that she developed, and his wife had died 2 years before, and nobody in the family had any experience of disability, and it was something that'll, it's not kind of predictable where it'll go, but it'll be a serious kind of chronic disability, and he's got no experience at all. And I said, well, how do you know what to ask for in these? And he said, well, I just assume that they'll tell me what I need and that we'll all kind of get through it okay. And I'm not quite convinced that was quite how that will go, although he lives in a fairly rural town where actually they do have quite a strong community together, and so so maybe he will get some of that support. But I think it's absolutely an issue. I mean, it's conceived of and talked about like by the economist in the Productivity Commission who designed it as being, well, this is a consumer system. You go out and you go and get what you want, but that so it presupposes that you know what you want, and when you do, that it exists out there for you to buy, I think one of the spaces that's more worrying about this is around people with cognitive impairments, and we in a project that we recently finished where we spent quite a bit of time with people with cognitive impairments who've been through the scheme. They and their family noticed very little difference to what had happened before. There were very little changes to their services, although the providers were getting more money for the same services that they've been delivering before in some sorts of cases. So you're right, it's a really important issue. Yeah.
Great.
It was just a thought with your last paper that some of the interviews we've done with parents of children who've got really complex healthcare needs, personalised budgets have been either seen to be quite good or kind of a bit of a dead loss, and it seems to be the one that the parents who are cleverest at navigating systems that are best using those things. That's right. But you know, not having read the paper, but the notion of craft and graft is absolutely what they do.
Absolutely.
To do that, but nobody teaches them.
No.
Apart from sort of the connectivity they have with other parents.
Yeah. Yeah.
And it seems to me that they navigate when they've talked to us about it is that the budget's changed, but the systems that they're navigating haven't changed at all. So everything else is, you know, apart from the flux that goes on all the time, nothing really has changed within the system, apart from the fact they can now spend the money.
Yeah. Well,
ish.
okay.
Yeah. And so it seems that kind of only one half of the equation has really changed for them.
Absolutely, and what you've done is you've subsumed all of the. It's got more efficient because you subsume all the transaction costs into the parents, rather than into the professionals. So you can, like here with direct payments, the difference between direct payments and individual budgets, there is a mechanism to self-manage in the NDIS, and very few people, I think it's less than 9% of people self-manage, take the kind of cash and operate in that way, because it's an incredibly complex process to go through in terms of accounting. So I have in the Public Service Research Group, one of my colleagues is a professor of accounting, and he has and his wife works in disability services, and he has a son, is 16, 17 and has chronic autism, and the professor of accounting can't do the accounting to account for the payments that they take out of this, which, you know, I mean, there's something about academics not being able to do anything practical there, but, you know, kind of jokes aside, you know, where you've got a professor of accounting can't navigate that system, it's a bit of a worry, and kind of explains the low take-up of that as well. But yeah, you're absolutely right. The amount of work that goes into that isn't seen at all. And when I went to talk to some people recently about early childhood intervention services in the federal government, and they were saying, well, so people who have a child with a disability and have no experience of this sort of stuff, what do we need to tell them? What are the bits of information? What are sort of the 5 things that they need to know? And we had this it was a very confused discussion, because I was sort of saying to them, why do you think there's 5 pieces of information that's going to be kind of the same across everybody? I said, well, if it was me, I think I'd want to be put in touch with somebody who was a bit like me, who'd been through it. And they was, well, that's very nice, but no, that's a bit too kind of wishy-washy. We need a brochure with 5 things so we can tell. I said, well, the first one is find somebody who's like you, who's been through this recently, because that's going to be the most trusted information, and be able to, as you say, hopefully shortcut some of that really hard work the parents have to do to navigate these systems.
Do through social media or through peer-to-peer befriending, which works really brilliantly. But it's not seen to be...
It's not valued.
It's not valued, but it's probably the most important. We're doing some work on befriending, and it's probably the most important thing that people could do and invest in.
Absolutely. But like advocacy as well, it's a thing that seems to sit outside the system. It's a nice addition if you kind of can get it, but it's not something that anybody really needs to fund. Yeah.
Thank you. It's really interesting.
So I think that was just picking up on some of the stuff that Bernie sort of said, and it was just really a question. There seems to be almost a dichotomy between what, to me anyway, between what Axel and yourself described with the sort of idea of craft and craft, where we all, and I think that's very much true. I mean, I'm finding that myself, where it's the idea that basically if everybody sort of works together, they'll come out with things. But then you're describing almost an us and them kind of situation, where you're saying that there is a need for this specialist knowledge, or people don't necessarily know what they need, so there's obviously still a need for somebody who is a specialist or something, who has a broad, rough idea of what people are going to be like. And would you describe that as a positive, is it still a boundary in a way, isn't it, between the professional doing the assessment, helping the person, the care planner? Is that like a positive thing, Bill?
Well, I think what there is there, you're absolutely right, it's a really positive set of knowledge around, and because the thing is, your care planners who are assessing like really different people from different backgrounds, different ages, different disability types, you can't be a specialist across all of those, and I'm not convinced that kind of going down the line of, say, having, well, you're the planner for MS, you're the planner, because actually then we get to the problem of people have multiple kind of comorbidities, and actually they're really interesting. We did a project recently, as a slight aside, but we did a project recently which we co-produced with people with disabilities. So we trained 9 people with disabilities, and they were the researchers. They drove this piece of research and what have you, and we wanted to when we selected people, there were a lot of people who applied who were very experienced in research, and we wanted to take people who didn't know a huge amount about research, would be of a profile which would make them eligible for the NDIS when it rolled out in their area, and who this would be a kind of a capacity building sort of thing for. And we had this kind of quite in an employment kind of context, and careful what you say around this, because we've got this quite difficult discussion of, well, can you tell us kind of what your disability is, given this is a kind of a part of this. And what was really interesting is, so we had that conversation, then we got a couple of months into the programme, and people said, oh, you know, when we had that initial thing and I told you this was it, because that's my, like, you know, cerebral palsy is my all singing, all dancing kind of disability, but actually I've got a mental health issue, I've got this and that, and actually you know, this is a difficulty with it. I've got, you know, there's a lot of different things, but I have to put myself into kind of one box or another to do some of that work. So I don't think kind of just having specialists who, but I think being able to signpost is the point that kind of was making about signpost to groups who do have specialist knowledge about a variety of these different areas.
Certainly when I've interacted with those groups myself, because I have as a gatekeeper, as a way in to get to actually speak to the parents and the families themselves, the best, as awful as it sounds, the groups that offer the best advice are those that cater to a wide variety. So you have parent care forums here particularly, and they're very useful, but when you actually see, I'm a member of some of those groups now and actually follow some of the conversations, and you can see that there's a variety of different people who all provide different parts of advice, and then you get that kind of joined up knowledge then, in it, if that makes any sense, because we've all negotiated different aspects of the system and can sort of come in.
And hugely important. And the other kind of dimension to this is in terms of people from culturally and linguistically differentiated backgrounds, and Aboriginal and Torres Strait Islander people, they're very, very underrepresented in the NDIS. I think there are less than 6% of people from cold backgrounds, something like that. Again, low percentages of people from Aboriginal, Torres Strait Islanders, and then backgrounds, and then you get into these kind of really complex kind of intersectional type discussions, and the challenges the system isn't set up to address these sorts of things at the moment. Now it's an immature, you know, as I say, I don't want you to think I'm kind of bagging this entire thing too much, because it's an immature system in some ways. It hasn't come to complete fruition, and if you look at the policy that was developed around it, I mean, it's incredibly kind of loose, and it's developing as it goes on along. I mean, as I said, the National Disability Insurance Agency, the agency that oversees the NDIS, the guy who was the chief exec of that until recently in its first iteration, he described it as being a plane that was being built while it was in flight. You know, and given that you're going to have these sorts of issues that arise, the challenge is how you respond to those, and responding to them in a positive way so that you can address some of those issues. And as I say, where you then have a response that becomes, well, we aren't getting enough people through the care planning process, let's do it all over the phone. That's not, you know, that doesn't seem to be the sort of response that you might go with. Yeah.
Thank you.
I'm coming at this from a slightly different perspective in that I work for an arts organisation, but we have become a service provider for learning disabled adults through personal budget, so they kind of pay to receive an arts service from us. I'm just quite interested in whether those boundaries where organisations that are not sort of social care or health organisations are crossing boundaries, because I think we have found ourselves crossing quite a massive boundary over the years. But is that happening through the scheme? You know, or is that not happening? So are mainstream organisations providing services that can be paid for according to the interests, or
So this is, I don't know how widely this will happen. This is a debate I've tried to have a few times with some people, and interestingly, not long after the scheme was launched, I wrote a piece that was in the Australian Conversation, which was around sort of saying, how much choice and control do we really, are we willing and able to give to people with disabilities if they decide to choose very different services to those that we traditionally have? I drew on some of the experiences from England that you'll all be kind of familiar with, of where people went for very different, and there's a bunch, there's a bunch of those kind of quite apocryphal kind of examples, and more of them are towards that, the kind of middle in terms of what you're talking about, and it got a huge amount of reaction, and what was really interesting is it became quite apparent that it's back to that thing. I don't know how different it is here, but we're kind of fairly happy to throw money at services that we don't know that they work, provided they look a bit boring and not very sexy. But the minute they look a bit exciting, then there's kind of less willingness to fund these sorts of things. So I remember going on at this national radio show where one of the kind of presenters said to me, "Okay, Helen, I'm kind of down with the sex work bit of kind of spending money around that. But here you said about going on holidays, that's just not acceptable." Using care budgets to kind of go on holiday. And I was saying, well, if it meets the outcomes, then what's the kind of problem? One of the challenges is today a lot of the planning processes, because of the skills issue, have remained tied to very particular kind of line items. So even it means you have to go through revisiting your care planning process if you find that the therapy type that you want, you kind of change that. So there was a woman who I was working with recently whose son was having difficulty in swallowing, and so they'd got a line item in their funding package to get services from a dietitian, and they went to the dietitian and they agreed actually it probably wasn't a dietitian they needed support from, it was a speech and language therapist instead, and had to go back through and go through a big revision of the care plan to move from that service to another. So they have remained very tied around quite traditional services. When you challenge people around that, they say, well, this is the first iteration. When we do it next time, we'll do it much better. We'll be much more innovative around this. But I'm not convinced that happens in a wholesale way, and I don't know how willing people are to go there with some of that. But as I say, we've got some of these. I've got a study that's kind of mapping different providers and different entrants to the markets to see whether we get different services emerge in those sorts of ways, and whether we do manage to kind of pull services out of what are in some areas kind of some really big providers who have the kind of the entire game kind of sealed up, and there's very little competition, and the barriers to entry are so significant in some of those areas that people are not going to come in and challenge those. And the other sort of important bit of this, that I should say, that's very different to the English context is the level of certification that professionals have to work with people. So you have to have a certificated level of ability. So we couldn't have a personal assistant like you have here who's got no experience or no training. You have to have somebody who has a vocational qualification in disability, which in some senses you can see in a protection kind of way is not a bad thing, but also it's really expensive, and it means you end up you've got really traditional looking services because you can't change it and there's nobody to change those.
It's interesting that what sometimes gets a bit out of view is that even within the UK, this whole ideological edifice of choice and control is one that's particularly pertinent for England. In England, and there are the devolved governments, Scotland, Wales, and Northern Ireland, either gently refuse to acknowledge it, or sometimes even explicitly undermine that sort of like ideological drift.
Or that's the only way to deliver. I mean, if you look at the Norwegian experience, what you get is a focus around choice and control, but that's not through giving you the budget to do that. You have a choice about which provider that you work with, and the choices that people make tend to be relatively limited, but between a user-controlled organisation or local government is typically the ones that people choose. Then actually they put a lot more money into the case management process to actually genuinely give people choice and control about that, and you can do it without giving people money.
Julie.
To some extent, you've answered my question just between putting my hand up.
Okay.
Skills, values, and attitudes, organisational factors. Anything research-wise around what makes for an effective navigator as opposed to a less effective one?
Yeah, I mean, from our work, I don't know. To date, some of that will come out in the local area coordination stuff. Again, like you say, it tends to be people who have who are very embedded in communities and understand them well and take the time to understand people and what's important in terms of their kind of life. I mean, this stuff isn't. I think we overcomplicate things sometimes, isn't it? It isn't kind of rocket science, and it's a really basic stuff often that we forget kind of along the way. But I certainly think that if we don't value those roles and we don't recognise them and we don't reward them, they tend to be, as I say, these bits that sit outside of and aren't valued in very significant ways. I think that's really problematic. I think if that's a really important part of the system, we need to make sure we value it really well and not just assume, oh, it'll happen, somebody will pick it up out there somehow. Yeah.
One of the interesting things is also when I worked in employment support services for people with learning disabilities, the drive was always, especially from policymakers, to standardize and to canonize, as it were, a particular portfolio of skills around this. The hope was, if everybody does the same, everybody knows what they're doing, then they can deliver better services. But as you said, very often it's just really intuition and really good sort of like empathy, with working with the people.
And having time to do it as well, that's one of the challenges.
Okay, another question? Yes.
I was just going to ask the role of the local area coordinator. Is that something that Australia have picked upon from the UK, where you do have the local area coordinators in the local authorities, and whether there's any research about the effectiveness of their role in prevention and early intervention? Yeah,
I don't know whether it's come from that or not. What's really interesting about the kind of the Australian development of the scheme is it sort of said, we'll go down this route because lots of other people are doing, but then hasn't necessarily learned from the evidence in other places. And Simon Duffy has been out to Australia a few times kind of saying, look, there are a bunch of things that you definitely don't want to do if you're going down these sorts of routes, and I'm not sure how much that's kind of been heard. I mean, my understanding it came out of going of some of the questions around saying, well, will people know what they want in these services and how to kind of navigate them, and saying, well, okay, we'll put this other function in and that will do all of that sort of work. People who there's an organisation who we work with quite closely that has a contract to deliver local area coordination services in an area of Victoria. And when you talk to some of the people who are involved in this, they can't really tell you what's involved in a local area coordination role, which is kind of worrying. And I know the evidence around prevention and early intervention is difficult kind of anyway, for some of the similar kind of evaluative reasons that evaluating collaboration is difficult. But there's just a general sense of, yeah, well, we've focused on getting this 20% of people onto these plans, and we'll kind of worry about that other bit later. But I think if you're operating an actuarial model, that's hugely problematic, because it really resides on that local area coordination role happening well. So yeah, I mean, if anybody has any good evidence around out of the UK around those local area coordination roles, it'd be really good to get access to that and put that in front of some people.
Drawing this to a close, how we need to mention at least one thing, because you didn't mention it, as far as I think maybe I overheard it, and that is really to the credit of this project, that this project was actually generally co-produced with people with people with disabilities, and that's really clearly probably has been a challenge, but also probably very rewarding aspect of this.
And we launch, I mean, if anybody's interested in the findings around consumer experiences of this, we launched that report in a couple of weeks, and that'll be available online. And some of the drawings that I had around the quotes, we did a community forum where we went back to the people that we'd interviewed and some providers in local areas to say, this is what we think we heard from you, is that right? And we took a visual artist with us who kind of captured it throughout the day, so when we report it, we'll kind of have the boring long report bit, but then also have some cool images that people can look at instead if they don't want to read all of those words. They'll be for the ministers anyway.